fascia, tendon, or acute injury or strain causes a release of mediators, bradykinin, prostaglandins, and histamine. Platelet and mast cells are recruited. Fibrocytic nodules expand and stretch the muscle. There's lack of oxygen in the muscle. There's local acidity. And sensitive muscle nociceptors are converted to trigger points. What is the clinical presentation? I'm sure all of you out there as physical therapists and massage therapists know that there's pain. It could be local or referred. It could be stabbing, burning, or dull. The symptoms may include tenderness or a jump sign where you push on it and a person jumps. So again, what causes trigger points? Poor posture, slouching. This affects muscle contraction, tissue length, and muscle length between the neck flexors and extensors of the body. Stress and emotions, tension, especially anger, held in our upper trapezius muscle. Trauma directly affects contractile fibers, including the actin thin filament and myosin thick filaments. Surgery. Surgery cuts open tissue, right? So the area will be swollen and hot and painful. Biomechanically connected tissue and muscle above and below will tighten and protect. Muscle imbalances. So where do these form? Where do trigger points form for the research? Well, the research shows that they're more common in women more than men, and there's frequency more in the head and neck, scalenes, levator scapula, upper trap, shoulders, and then QL. That's according to Gellert D. et al. In 2016. The research of trigger points, there's not very much research on evidence-based research in the form of meta-analysis and systematic reviews. However, in reducing trigger points, it's been shown that manual therapy and exercise is superior than high galvanic or electric stimulation interferential current. Per the research, there's prevalence in trigger points in the supraspinatus and medial deltoid, coupled with a bicep tendon. So if someone has trigger points in the upper subcranial, it can refer into the side and temporal region into the eye, as you can see here. How do we affect that as physios? We do suboccipital release, hands underneath the suboccipital region or the occiput, fingertips high, and distract. Or if you take your hands on your chin, 2 fingers, push down, your heel of your hand on your occiput and push up. That feels really good. That's a subcranial stretch. Excellent to teach your patients who are having headaches, subcranial pain, et cetera, et cetera. Referral pattern for upper trapezius goes into the supraspinatus and the medial deltoid. Infraspinatus referral pain along or infraspinatus can refer into the medial deltoid, in the medial part of the shoulder, all the way down into the fingertips and the anterior bicep. So how do we stretch the upper traps? I want everyone to take your hand behind your back, hand on your head, and gently lean to the opposite direction. That should feel really good. That's called the upper trapezius stretch. And then the infraspinatus stretch, take one hand and the other hand, put them together and pull towards me. So I'm opening up my middle back. 15 to 30 seconds is ideal, 3 times, at least twice a day. Levator scapula, C1 to C4, can refer pain into the medial scapula as well as the medial deltoid. Scaling referral pattern, C6 or C3-6, C2-7, C4, C6 are the 3 scaling muscles. They can refer to the medial scapular border, medial deltoid, all the way into the first 2 fingers. So there's the levator stretch, hand behind your back, looking to the opposite direction, pulling down diagonally. And then the scaling stretch, cross hand on the chest, look up, drop your head, and rotate to the same side. Great stretch. 15 seconds to 30 seconds, 3 times, at least twice a day. Multifidi can refer into the glute, And the famous muscle that I love is called quadratus lumborum. Goes from the 12th to the iliac crest. You can see here, if trigger points along the lateral border of the QL, that refers to more of the gluteus medius and the ITBN proximally, versus more medially trigger points, that's refer more into the piriformis region. So how do we stretch the QL? There you go. Sitting or standing bent over, twisting. The one again against the door or doorway with both hands over the side and leaning the opposite direction. Or my favorite is kneeling and leaning to the side. We need to keep soft tissue flexible and pliable. So foundation behind ISTM, also known as gua sha. Gua sha is a form of ISTM used for centuries in Asia and communities by acupuncturists and practitioners. They believe that gua sha releases unhealthy bodily matter from blood stasis with sore, tired, stiff, or injured muscle areas. That stimulates new oxygenated blood flow to the area, promoting repair, regeneration, healing, and recovery. Gua sha means to scrape. It's defined as instrument-assisted unidirectional press to the body that creates a therapeutic petechiae. You can see here, which means to bleed, a breaking of blood vessels with these two pictures. The scraping technique dates back all the way to 220 BC. So why do this? Why use ISTM? Well, the Romans used it the Romans and the ancient Greeks, I should say, in Roman baths, used these stridules to scrape dirt and sweat away. The history again goes back to the 1980s in Gellert Chamberlain, orthopedic James Syriacs expressed the clinical use of transverse friction massage. It emerged in the 1900s, formally into 1994. It evolved with two athletes developed instruments that they used to treat soft tissue fibrosis. Then Graston came along. In 1987, David Graston suffered a knee injury, leaving himself in need of reconstructive surgery. He treated himself when traditional rehabilitation failed because he was upset he was not getting the help he needed. But he had an idea. He developed what would be the prototype for 6 Graston instruments. Instead of the scraping technique to remove Sha, his idea was the Graston technique would develop with the goal of detecting and alleviating adhesions. And it was determined that the stainless steel is able to generate the most vibration and superior to other materials detecting adhesions and restrictions. So this course is not about Graston. I'm exposing you a little bit about the history, but it's about ISTM. Since the development of the Graston technique, there's nearly 25 competitors. And over the past 25 years, the Graston patent expired. Hawk grips, FAKTR, Smart Tools, Rock Tape, all have emerged. So why should you consider using ISTM? There are numerous benefits. It complements manual therapy. It can be used immediately on postoperative patients. It can help painful patients. There's carryover from visit to visit, and most importantly, mechanical advantage in saving your hands. What's better than saving your hands, right? Research. Research is boring, but we've got to talk about it. It's important in the fields of medicine, physical therapy. It drives the progression of any field, and understanding is vital. So I hope if you're not reading journal articles, you are, because research is important to understand what's going on and the levels and types of research and the grades, which I'm going to talk about. So in terms of the research and levels of evidence, the hierarchy, the highest is evidence-based, meta-analysis, systematic reviews, research studies, case studies, and ideas and opinions like Dr. Jones said so, which is at the bottom. So we want clinical practice guidelines to be the most respected and utilized when we talk about research. Then meta-analysis, systematic reviews, and RCTs. However, there's very limited research on high-quality articles with ISTM. With regarding the shoulder, there's limited or few randomized control trials. In a study by Cavallo et al., he went to examine the effects of ISTM for the treatment of subacromial pain. The conclusion was that ISTM improved pain-free range of motion compared to the non-control group. Lumbar research, Lee et al. In 2016, investigated the effects of Grasson technique and general exercise on pain and range of motion with chronic low back pain patients. The results were that the lumbar range of motion group significantly increased post-intervention both in groups, whereas the Grasson group and general exercise resulted in pain relief and increased range of motion. Same thing with the knee. A randomized control study by Markovic wanted to compare the effects of one session of ISTM fascial abrasion technique to one session of foam rolling. The results were that the ISTM fascial technique was more superior than the foam rolling. In the ankle and the elbow, there's limited high quality of RCTs. And McCormick et al. In 2016 conducted a randomized control trial examining the effects of soft tissue treatment plus eccentric exercise for Achilles tendonitis. The study design was they randomly assigned either a soft tissue treatment, an eccentric exercise group, or eccentric exercise only group. This lasts over 12 weeks. The conclusion was the soft tissue treatment plus eccentric exercises were more effective than eccentric exercises alone. The principles, what is and benefits of ISTM? There are twofold. One, it's to target the tissues deeper than your hands. It has several effects on different parts of the body systems. It helps to restore optimal soft tissue quality by causing controlled microtrauma to specific area, stimulating increased local inflammation. This inflammation accelerates the body's response, causing a cascading effect. It increases blood flow, nutrients, and fibroblasts to the area. Furthermore, this results in the synthesis of collagen and maturation of the tissue. So it's utilized and implemented based on several factors: the stage of tissue healing, repair, patient's condition, comorbidity, date of surgery, date of injury, pathology, and most importantly, type and location and desired treatment response. Research shows that one of the best ways to repair tendons is by stimulating fibroblasts. Fibroblasts are the cells that create new collagen fibers to repair tissues. ISTM has been shown to increase the stiffness in tendons after injury and promoting faster healing times. By creating microtrauma to a tendon through ISTM, we stimulate blood flow, nutrient flow, fibroblast synthesis, resulting in tendon repair. The benefit, again, of ISTM, we can reduce pain. Pain can be reduced because when there's pain, this is accompanied by inflammation. Range of motion will improve. Flexibility improve. Mechanical response and neurophysiologic response of ISTM. So let's talk about scar tissue versus adhesions. Scar tissue is a natural occurrence from the inflammatory response that's seen after trauma or injury. Adhesions are fibrous bands of scar tissue that form between internal organs and tissues, joining them together abnormally. The adhesions form as a natural part of the body's process after surgery in a similar way that a scar forms. ISTM is thought to stimulate connective tissue remodeling through reabsorption of excessive fibrosis, along with inducing repair and regeneration of collagen, secondary to fibroblast recruitment. This, in turn, will result in the release of breakdown of scar tissue, adhesions, and fascial restriction. So when a stimulus is applied to the injured soft tissue using an instrument, the number of fibroblasts along with fibroconnectin through localized inflammation, which will facilitate synthesis and realignment of collagen. The problem is a lot of the studies have been looked at rats. Can rats talk to us? No. Can rats give us feedback? No. Can we look at what the rat thinks? No. So mechanotransduction, or mechanical effects, is the physiological process where the cells respond most to mechanical loads. When a rigid instrument is applied along the skin surface, this creates a deformation of the extracellular matrix, also known as the ECM. As the force continues, forces are transmitted to the cytoskeletal filaments, which are tethered structurally to the nuclear lamina via connection to the complex proteins. So when we use manual therapy, and this is applied to skin, mechanical stimulation will trigger an inhibition of nociceptors and release of the body's natural opioids via the descending inhibitory pathways from the central nervous system and the spinal cord. The deeper the pressure, the deeper the tool, different mechanoreceptors will be stimulated. Types of tools. Did you know all these tools are available? There's buffalo horn, there's jade tools, there's plastic tools, metal. Buffalo horn are very much inexpensive and used by Chinese gua sha practitioner. They're between $5 to $10. Jade tools are heavier, more girth, easier to hold, can be slippery, but they cost between $10 to $30 and also can break easily. Plastic tools are relatively new and come in different shapes and sizes, and one benefit is they can easily be gripped and maneuver. They're great for desensitizing someone with the hypersensitivity, especially CRPS, or what used to be called RSD. Wood tools are not well known, but the benefits of these tools contour very nicely. The patients feel the tools on them. Again, great for patients in chronic pain. Have you ever used them? The stainless steel tools are the best product. This is the Fibroblaster Edge tool. This is the IM tool, and the FAKT are a little baby bear. What is important about an ISTM tool? The bevel edge, how it fits, and how it works are the most important qualities to look for in a tool. There are a few courses that go through for physical therapists and allied health professionals, such as massage therapists, that offer both online, home study, or live seminar ISTM training. Pinnacle Training Consulting Systems does. Of the providers that either offers online, live seminar, or both format, I have not found one provider that explains the standardized approach, which is what you choose for your first tool with a patient. So let's talk about a clinical example. A patient comes in with a total knee replacement, tremendous amount of pain, swelling gait, guarding, and presents with hyperesthesia. What are typically going to be tight? Well, typically are the quads, proximally, hip flexors, gastrus, and glutes. So the goal of therapy, PT goals, is reduce swelling, improve range of motion, right? We can also use our toolbox and look at passive modalities such as ultrasound, ISTM, manual therapy, and vasopneumatic. We need to use clinical reasoning, examine behavior of the symptoms. When was the surgery date? How much healing has gone by? How is the patient moving? What's their body language? How irritable, how severe are they? And what was the previous night like? This dictates the plan for the treatment. So we know that the entire chain must have mobility in the ankle, stability in the knee, mobility in the hip, and lumbar in the spine. Based on the behaviors of the last slide, I typically begin with myofascial release to the calf, proximal quadricep, and then soft tissue massage with lotion, or STM. The first day, I may not use ISTM. If I do, I may use plastic or wood to tease the tissue. This prepares the tissue for greater mechanical loads, demands, reduces the layer restriction, decreases stimulation, nociceptors, mechanoreceptors, and decreases pain. Bodies are like an onion. Remember that when teaching your patients, or birthday cake. Since my birthday's today, woohoo! Happy birthday. It's all good that we want to peel away the layers of the restriction from the outside to the inside. We need to address the most important layers first, then address the patient's needs. Soft tissue, fossa, muscle, and bone. Motion is lotion. That affects everything from the muscle all the way down to actin and myosin. Foundational strokes, base concept. So it's important to remember that the size of the treatment area will determine which tool that you'll use. The larger the instrument, the larger the treatment area, such as you can see here in the hamstring. Instrument handling, 2 fingers versus 1 finger, or I should say 2 fingers or 1 hand versus 2 hands can give you more control. Speed or stroke. With hypertonic facilitated tissue, consider using slow, longer strokes. With inhibited or shortened tissue, important to remember that the treatment stroke follow the direction of the bevel facing both a depth and angle that targets the tissue. The edge of the tool. Usually there's 2 sides to a tool. There's a bevel side up and a bevel side down. The bevel side up provides a firmer edge. This is deeper and increased compression and increased resistance forces are placed on the tissue. Bevel side down, softer treatment, softer edge, desensitization, less compression. The size of the tool. Remember, there's a lot of tools in the market. A larger instrument is ideal for covering larger surface areas such as the quads or lats. Smaller instruments are for small areas like the hands or fingers or feet. Treatment angle. The treatment angle can be modified, but typically the most treatment strokes begin at a 45-degree angle. The greatest amount of shearing force, capable of destruction, bruising will occur if it's held in a vertical position. So 45-degree angle is ideal. Direction of the tool. Scan the tissue both directions from proximal to distal and distal to proximal. Then apply the tool transversely along the muscle, finally diagonal within the muscle belly. Feeling for restrictions compared to affected side and side treated. Speed. When first starting a patient, it's important to start applying a smooth stroke. So again, there's limited information on the types of stroke pertaining to ISTM. There's really 6 foundational strokes: the sweeping stroke, fanning stroke, brushing stroke, strumming stroke, framing stroke, and J stroke. Sweeping stroke. You can see the sweeping stroke is really scanning and assessing the tissue. It can be one-handed or two-handed. Note the upward bevel edge allows the tool to dive into the tissue. The stroke is a broad stroke designed to treat large areas and formed in one direction longitudinally. The grip, one-handed or two-handed, great for treating large areas like the quads, hamstrings, ITBN, or lumbar region. Great for clinically for the total knee patients, quadriceps, ACL, PFS, chronalgia patella. Also for lumbar spondylosis. The fanning stroke. The fanning stroke is an ideal stroke for crossing over multiple directions. So one-handed fanning stroke on the top and two-handed stroke on the bottom. The two-handed stroke involves one end of the instrument is fixed while the other hand passes in a large area. So you can go either distal to proximal or proximal to distal. Brushing stroke. This stroke involves using a smaller stroke as compared to sweeping and fanning strokes, which are larger. The technique involves parallel to the muscle fibers with tools applied, performing short strokes on the area treated dragged, then picked up, dragged, picked up, dragged, and picked up. Clinically, great technique to prevent for adhesions, post-surgical conditions such as ACL, reconstruction, total knee revisions, and similar movement dysfunctions. Strumming stroke. It's perpendicular, not parallel, not perpendicular, completely straight, but angled of the targeted tissue between approximately 45 to 70 degrees. The stroke is very effective over tendon and ligament structures, such as knee arthritis, PFS, lateral medial epicondylation, and post-surgical conditions, targeting the retinaculum and soft tissue adjacent to the knee. Framing stroke. Framing stroke is performed around bony contours, such as the patella. This technique involves short to medium straight or circular strokes. It's like cleaning fat off of a steak or a meat. The technique is multidirectional, as seen in the figure above. Clinical application, again, great for, but not limited to, patellofemoral syndrome, total knee replacement patients with lateral epicondylation. The J stroke is very effective to mobilize soft tissue interfaces, such as the IT band, rectus spinae, or muscle belly interfaces. It's performed similar like the brush stroke, making sure that the instrument not be flat on the skin, but lift and laterally kind of off the end of the stroke. This will assist in mobilizing or splaying the targeted tissue. So what is your dosage? Remember, everyone is like an onion or a birthday cake. Connective tissue needs to move. This includes fascia and muscle. So when you're working with patients, think of this onion or cake analogy. Depending on how the patient feels, I begin with myofascial release, and then I use ISTM. Additional techniques in to improve soft tissue mobility include soft tissue massage, could be active release technique and distortion fascial model. So we want to warm up the tissue before we use our hands, right? Or before we use ISTM. So maybe walking, using the bicycle or a hot pack. Choose the appropriate instrument. As you work through the tissue, notice and feel irregularities with both your hands and use the instrument and gradually increase the depth of your strokes. Treatment time, 30 to 60 seconds or up to 90 seconds per area, and approximately 3 to 5 minutes for one area to be exposed on ISTM treatment. Reassess, re-examine the range of motion with the goniometer. Then move on to stretching and exercise. So to finish the treatment, I usually do a few light, broad, easy strokes to calm the tissue down. Post ISTM, I'll have the patient move or utilize the new range of motion gained. Indications. What is the purpose of ISTM? Remember, the purpose is to restore and improve range of motion and soft tissue mobility. For acute injuries, the goal is focusing on reducing swelling, decreasing hypersensitivity. So we want to do light strokes with an acute injury. For chronic injuries, such as a tendinopathy or tissue that's really, really taut, where the goal is promoting fibroblasts and breaking of crosslinks, we use a more firmer stroke is recommended. So indication, limited range of motion, decreased soft tissue joint mobility, muscle imbalances, neural restrictions. They can't perform their exercise without pain. So precautionary, we want to look at someone taking anticoagulant medication. This is increased risk for bruising. Diabetes. We want to be careful with some inflammatory conditions with cancer or pregnancy. Pure contraindications. Patient says, no, I don't want to do it. Acute injury, or it's bleeding or infected, active over the active implant, carotid artery, they have a cellulitis or present DVT, or myasthenic ossificans, and they have an open wound. Finally, over a fracture site and osteomyelitis. These are all stop with contraindications. So ISTM can be effective for plantar fasciitis, ankle sprains, Achilles tendinopathy, posterior tibial tendonitis, PFS, osteoarthritis of the knee, total knee replacement or revision, ACL, ITB syndrome, hip arthritis or gluteotendinopathy, as well as a total hip replacement patient, hip bursitis, rotator cuff tendonitis, tendinopathy, affecting the upper trap deltoid scapular border, shoulder impingement, bursitis, rotator cuff repair, or the elbow. Now I'm going to show you some techniques for the cervical region. So here you can see on the left, on the upper trap, I'm doing a sweeping stroke with the multi-purpose hawk grip tool, going from proximal to distal, right in the upper trapezius. On the right is a sweeping stroke to the left upper trap using the edge tool, which is an amazing tool because it fits in a nice bit of your hand. J stroke again on the left with the upper trapezius, strumming with the grizzle tool from Hawk Grips. Great application for cervical arthritis, whiplash, and then finally on the right, strumming to the right scaling in border of the upper trapezius. Application is, again, for thoracic outlet syndrome. Shoulder techniques. Brushing technique to the left supraspinatus. Whiplash. Supraspinatus tendonitis, tendinopathy. On the far right is the large handlebar, where you can get into the scapular border and mobilize from medial to lateral. Great for frozen shoulder or adhesive capsulitis. Lumbar techniques. Brushing technique to the paraspinals and left QL. Application great for SI problems, patients with spinal stenosis or DJD. J stroke to the distal aspect of the rectus spinae and superior aspect of the sacrum. Patients with lumbar disc disease or SI discomfort. I would not use ISTM with an acute disc injury, both cervical or lumbar, just to let you know. I typically stay away from doing it. I use my hands. Excuse me 1 second, let me shut my door. I apologize, your audience. I just had some noises I want to. The lumbar, again, you can see here a fanning stroke, two-handed fanning stroke on the QL muscle with the banana bear from Hawk Grips. And then on the far right, the handlebar in sideline position. Great technique. So you're doing the technique, ask them to move and do the technique again, or move with the actual side bending while you're doing the technique. Great technique. Two-handed fanning technique, stroke to the thoracolumbar fascia. Over the right QL, remember QL goes from iliac crest to 12th ribs. Applications, SI patients, spinal stenosis, or degenerative joint disease. On the right is a one-handed fanning stroke to the right QL muscle. The line of force going towards iliac crest. So on the left, the line of force going towards the midline. On the right, the technique is going towards the iliac crest or going medial to lateral. Great for soft tissue injuries. ISTM techniques to the hip. Large, again, handlebar, sweeping stroke, using the handlebar to the right IT band, vastus lateralis and outer quads in left sideline. The stroke is performed away from the patient or toward their feet. So it go from distal to proximal or proximal to distal. Application, patients suffering from ITB issues, total hip replacement, hip bursitis, all can address that adaptive shortened tissues. Really effective technique. So distal to proximal or proximal to distal. So I have a handlebar here. This is one of the, from my fast releaser tool, our company. So again, two bevel sides. We have the bevel side up and bevel sides down. We're going from proximal to distal or distal to proximal, right? The chisel from Hawk Grips, that's the tool right there. The chisel is a brushing stroke from or proximal IT band and lateral aspect of the right greater trochanter. Application, greater trochanter bursitis, ITB, total hip replacement patients. Suffering from also bursitis as well. Great technique. Then you can do your stretching, you can do your joint mobs afterwards, recess their range of motion, and look at how they're doing functionally, or doing a squat or a lunge, right, or whatever the patient can do. Fanning stroke to the right gluteus medius. There's a two-handed fan going from lateral to medial on the left sideline position. These are, again, great for patients suffering from ITB syndrome, gluteal tendinopathy. Remember, why are we using ISTM? Mostly soft tissue injuries, such as hamstring injuries. It can be used on a hamstring problem. So I've got the handlebar again, and I'm going from distal to proximal. I'm sorry, proximal to distal, and then I can go distal to proximal, which is an oblique stroke on the left, or one-handed fanning stroke to the right lateral hamstring in an elevated position. So again, the application is great for hamstring strains, leg contusion, bonks, corkies, or contusions, right? So myofascial release first, soft tissue massage, then ISTM, or myofascial release and go right to the tool and then using massage afterwards. You're going to get more petechiae from using the tool on the tissue that does not have lotion. Well, sometimes patients cannot tolerate the pressure of the instrument, so I'll go right from myofascial release to soft tissue and then use the tool. Okay, that's my reasoning for it. The knee. Remember, again, strumming to the knee. The technique is perpendicular to the quadriceps and VL muscles. Great for total knees, patellofemoral syndrome, ACL, and knee arthritis or osteoarthritis. Great technique. ISTM techniques to the ankle. This is the baby bear in my hand there by Hawk Grips. So on the top picture, I'm doing brushing, sweeping stroke on the plantar fascia. I'm treating plantar fasciitis, going from superior to inferior, right? And the baby bear on the bottom picture in B is doing a brushing stroke using the hook portion along the lateral border of the plantar fascia. Again, another great for plantar fasciitis. Then you can do your splaying, your soft tissue massage, your mobs if they need mobs, get them moving, doing some ankle raises or ankle pumps, heel raises, squats, or something functional, or even bicycle to get the tissue warmed up, right? If they can tolerate it. Some patients are in chronic pain with plantar fasciitis cannot tolerate intense ISTM. So you've got to use your clinical judgment accordingly on what they can tolerate, right? Here's another using the baby bear from Hawk Grips. using the double bevel on the Achilles tendon. So this is for more for Achilles tendinopathy versus a tendinosis. Tendinosis being thinning, apathy, chronic pain in the tendon. Also great for affecting and treating plantar fasciitis. So remember, we're really trying to work the tissue with the tool. It's to save our hands. We want to warm up the tissue with myofascial release. Whether you go right to the tool and then do soft tissue massage, or you go myofascial release, soft tissue massage, and then the tool, is up to you. How irritable and how severity is the tissue that you're working on? How is the patient doing? That dictates your approach. There's the fanning stroke using the bevelage on the calcaneus. This is the baby bear, great for heel spurs, plantar fasciitis, or patients with posterior tibial tendinitis. Finally, the brushing stroke to distal peroneal tendons. I'm stabilizing the calcaneus, and I'm going from distal to proximal with a baby bear. That's the baby bear from hawk grips. Then I can take the baby bear and go over the malleus and flush out that swelling for someone with swelling along the calcaneus or on the lateral aspect of the everters. So great for treating lateral ankle sprains. Flushing out, using your hands, doing myofascial release, soft tissue massage, ankle pumps, and then at the end you can do ice or vasopneumatic compression, right? Really effective. So we have this course that we're working with ISOMT, and this home study course in ISTM is in the 12 chapters: foundation, research, principles, the physiology we talked a little bit about, the types of tools, strokes, indication, fascia, which we talked a little bit about today, trigger points, clinical patterns, ISTMs for the upper cervical and elbow and hip and knee, and then lower body, lumbar, and ankle. 2 course manuals, over to access over 20 videos. We hope to come to India in 2024. More information, you can go to our website here or to ISOMT.com. And most importantly, I want to thank everyone today who came out to listen to my presentation on my birthday, and most importantly, the opportunity to work with ISOMT to help educate you guys. I'll entertain any questions if you guys have any questions.
I will keep an eye on the questions, Chris. Well, I didn't know it was your big day today. Well, we wish you, all the participants over there are wishing you many happy returns of the day. We really thank you to do it on this weekend. We would have postponed it. Didn't know when it was your birthday. Well, so happy birthday
No problem.
to you.
No problem.
Enjoy your big day. And guys, I'm going to quickly show you, if you allow me, can you stop sharing the screen, Chris, if you don't mind? So I can show the people a little glimpse of the chapter that it looks like. If you allow me, then I will show you on our website. So this is the chapters that we have it on the website, where Chris in detail is explaining all the techniques around the trapezius. So we have a lot of demonstration practicals over there in detail. All right. So if you can see that, he's working on the upper trapezius and the levators with the tools. So we have the chapters like that, and Chris detailed home study course is there on our website. I'm going to show that too. Let me kind of open this up for all our participants over there. There we go. So if you see it on your screen, you go on our website called ISOM.com. on the certificate courses over there, and the first course that you see over there, the ISTM, Chris Gellert, the home study material that Chris was talking about is present on our website, the ISOM.com. Okay, you click on the ISTM course over there, and you will find more information about this course and the pricing and all. And see the course description. There are 12 chapters. There are 12 chapters, and all are filled with the demonstration of these techniques. The types of the tool, the types of the strokes, application, indications, fascial chain that Chris elaborately mentioned, the clinical patterns of movement dysfunction, the techniques of the upper body, the techniques of the upper body, part 1, 2, 3, 4, lower body. My God, they are like 12 chapters, and you can really help your patients with this ISTM workshop home study course that you can see it on our website, the ISOMT.com. Okay, so you go on the website and you will find this course on our website in the certificate courses. Okay, if you want to learn more, on the website we also have our 1-year manual therapy program. So ISTM, soft tissue, if you want to be a certified manual therapist as well, you can also access our website. You can see for the manual therapy and the dry needling. Chris is an important part of a team. Okay, so we really thank Chris to do this on a weekend birthday day. I really appreciate that, sir. And we hope the participants can gain more from your home study course. And we wish you good luck for today, and you enjoy your big day with your family. All right.
Thank you.
Chris, there's a question, if you can take 1 or 2 questions.
Of course.
People are asking that how often can we do the ISTM on a patient?
Sure. So the question is, how often can you do it? And my answer is, I would do it every visit. So I typically see patients twice a week. So maybe Monday, Wednesday, or Monday, Thursday. I probably wouldn't do it back to back. It might be a little intense, but I think definitely at least every other visit. And most importantly, it's a short duration. It's 3 to 5 minutes. You're not doing 15, 20, 30 minutes of it. So you want to use this to complement in your manual therapy toolbox, right? Your manual therapy toolbox is your soft tissue, your myofascial release, your ISTM, your dry needling, your manipulation, your stretching. So I think that it's a great question, but I would do it every other visit, and it works great. I've had a lot of success, and it saved my hands. My hands in 22 years, Dr. Kumar, still feel great. I'm 25 or 53 years now. I'm a year older, and I feel great. My hands are good. So I'd say use it every time. Every other vape time is good.
That's great. And another participant wants to know, is it safe in pregnancy?
It is. It's precautionary. So you want to stay away from areas that can trigger, obviously, like certain areas in the back and such. But as you know, with pregnancy patients, there is distension of what? Fluid. So they're going to be obvious fluid in the leg and the hands. So typically you'll see more of tightening in the upper traps, but their joints are loose or lax because of, again, their hormone. So you just want to be precautionary when you're doing it.
Yeah. Another participant asked that how can we get the tools? So maybe we can kind of talk about getting the tools mailed to India and your company over there. So we can have these tools over there, and the participants who want these tools to perform the instrument-assisted soft tissue, they can buy those tools from the website as well.
Exactly. Yeah. And like I said to you earlier, I think we can talk about, I've got some agreements and arrangements, Dr. Kumar, with companies here in the US, like Edge Tool and Hawk Rips. And there's a company, as I've been told you here, this one is called the myofascial releaser. It's a company in, I think it's Arizona, really good real tools. It's a whole set's like $140 US dollars, which is very, very cheap. So, and I would love, for us to entertain and talk about possibly coming to India to do a seminar, a live seminar, to go through this together in the future. So that would be something I love for ISOMT and you to think about. And for you guys listening and the participants, which I really appreciate, I'd love to meet you all and do a seminar in India. That'd be great.
Sure. In person, we will definitely meet you in India, maybe by next year. But I really thank you. Thank you so much, Chris, for doing this on a weekend, especially on your birthday. So thank you so much, guys, for joining us. I'm Dr. Parijat Kumar. I'm the founder of International Sports and Orthopedic Manual Therapy. Chris Gellert is an important faculty, as well as the instrument-assisted soft tissue person on our platform. So you can see the website and his home study course material on the website. Quite elaborate. Please go through it and feel free to buy that course so that you can learn in detail about different conditions, different strokes, different tools, and different sports conditions. All right. So thank you so much, Chris. We will sign off for today. Thank you all. Take care. Have a blessed day. Enjoy.
Bye-bye. I appreciate it. Bye-bye now.
Take care.